we're glad to welcome Dr. Brunnhuber. He's a medical director and chief medical officer of the Department of Integral Psychiatry, Psychosomatics, and Psychotherapy, and medical director of Diagnostic Clinics in Chartres, is it? He's an endowed professor for psychology and sustainability and senator of the European Academy of Sciences and Arts. He is interested in a variety of subjects that kind of link together for global health and integrative medicine. He's interested in sustainability issues, funding and economics of integrative medicine, finance and sustainability, and psychology of human beings. Please welcome Dr. Brunnhuber.
Thank you. Thank you. Thank you. Thank you very much. Thank you very much for the invitation to the Semel Institute, and thank you very much for your interest in that topic. It's been 10 years ago I had been fellow at UCLA, associated to the division of Amron Mayer and Yvette Taché on functional GIs, and now it's 10 years later, I'll be back. I'm not a basic researcher, and I'm going to present you ideas how and why implementing CAM, complementary alternative medicine, in day-to-day clinical practice. In the European population, there is a long history of CAM being used. There's at least 80% of the population having at least once contact to CAM versus about 40–42% United States. And two studies from Netherlands just published show that especially in the patient samples with mental disorders, the CAM frequency is even higher than in the ordinary population. In Germany, the vast majority, actually 52%, would prefer being treated with conventional and complementary medicine instead of conventional medicine only or complementary medicine only. And the visits to CAM practitioners exceeds now already the amount of contacts to the GP. So I'm not going to provide you meta-analysis, Cochrane studies, or clinical trials. What I would like to discuss with you during this lecture is two sets of questions. The first one is, why CAM in mental health? What kind of CAM? And how to do this? And the second set of questions is, what is the impact of CAM in clinical work? On patients, on staff, or even on the hospital as a whole? I'm going to press, here we go. Giving you an idea how that works and in which context this is happening, the first thing you might have to consider this is that CAM is happening within the German healthcare system. And German healthcare system means we have a 99% insurance coverage rate. Basically everybody in our country is insured. The second thing is patients with mental disorders stay on an average in Germany 24 days inpatient. And the third is we are reimbursed per capita per day. There's no fee for service on average. So if a patient comes in, I'm, as a CMO, relatively free to do whatever I want to do, even besides the guidelines, as long as he gets out of the hospital in an improved state. It's a standalone hospital. It's the largest hospital trying to integrate conventional and complementary medicine. Probably in Germany, it's a 724 admission, and we cover about an area of 250,000 inhabitants. It's an academic teaching hospital. We have collaborations with the PhD program, the Charité and the University of Dresden, and our training program is EU certified. 110 beds, just to give you an idea, 60 day clinic, and about 50,000 contacts through the outpatients department. So, why CAM? Why CAM in psychiatric health, in mental health? Besides the standard protocol, meaning besides guidelines and recommendations from professional medical associations, CAM should somewhat impact on symptom control, on output, on outcome, on side effects, on costs, on patient safety, on patient satisfaction. Simply speaking, CAM should somewhat influence the conventional track and modify the outcome. This is the goal. The question is, why should we do CAM as psychiatrists? I think there's at least 3 reasons why CAM should be done. The first one is the psychiatric care we're doing on a daily basis as practitioners, and probably does not differ much in Europe to the United States, is based on an evidence and a research evidence of at the most 25%. The rest we just do out of empirical experiences, not out of research evidence. New England Journal of Medicine published last year an article showing that 90% of the studies we're doing in our field are sponsored by industry, out of which only 50 are published. And out of the 50 who are published, 2/3 have a change in outcome parameters ex post. So for me as a practitioner, I'm left with an extremely small database making a decision on what to do with the patient with a mental disorder. So why not trying stuff which is not guideline? Why not trying stuff which has in part a 200, 300, 2,000, 3,000 year of history? The second reason why CAM in psychiatry is that at least in the European population and the European clinical cohorts, the adherence and compliance is low. It's less than 50%. And in the German population, about 40% of people getting psychiatric care do have 4 drugs or more, which causes a lot of problems with side effects and cost control. The third reason why using CAM in psychiatry is basically the question, are we so sure about mental disorders in general? JAMA launched a whole series of a discussion last year on that question, asking the question, we consider as psychiatrists mental disorders as brain disorders. But does that mean that we have to treat the brain? Maybe the brain is just the final pathway of long series of causes not originating in the brain, is one of the conclusions of the main editors of that journal. So if we only have a hammer, everything we see is nails. If we have different tools, we might see different things than just nails. So how do we classify CAM in Europe? One way to do it, we start classifying in that way. There is a 300-year history of so-called European naturopathy, European CAM. We call it the Big Five. And the Big Five implies hydrotherapy and thermotherapy, I'm getting back to that, which implies cold and hot pads and hyperthermia. The rationale behind this is to reset the autonomic nervous system, and with regard to hyperthermia, basically to increase the body temperature to 39 degrees, to cause an experimental fever to the patient. The second is changes in nutrition, therapeutic fasting and diet. The third, some form of exercise. The fourth, phytotherapy and supplement. And then the fifth, some sort of mind-body medicine which goes beyond the conventional psychotherapy. You can use these big five and extend them, and then European naturopathy would say, well, there's some cleansing techniques associated to it, like cubbing or detox. There's noodle therapy, I might get back to that later on, and some sorts of energy medicine. It could be Reiki or osteopathy or anything else. And besides this big five and this extended version, there's always parts in other medical systems, whole medical systems, which can be then prescribed to the patient, coming out from Ayurveda, from Chinese medicine, anthroposophic medicine, or homeopathy. So when we're talking about CAM in psychiatry, we basically have this classification in mind, trying to find out the best for each patient. The next slide shows you what we've been doing in our hospital. We prescribe about 50,000 additional CAM interventions a year to our patients, besides the standard protocol, besides the guidelines, as a CAM augmentation. And this makes roughly about 15 to 16 CAM interventions per capita per stay. That's the idea. This includes diet changes, noodle therapy, exercise, aromatherapy, phytotherapy. I will give you 3 clinical cases later on to be more precise about it. Acupuncture and different forms of mind-body medicine. For example, it might sound trivial to you, but when I took over that job 6 years ago, I started introducing 1 hour of silence to every ward every week, once or twice, to all patients, including staff. There's no side effects, I can guarantee. It brings down the stress level for staff and patients. And even though in the first 4 weeks people were a little bit kind of embarrassed not to talk for an hour, after 4 weeks, none of my wards wanted to miss it. It's not a big thing. Naturopathy, CAM, is not about big things. It's about very basic things. It's about common clinical sense. We sometimes miss when we do guideline approaches only. There's different rationales why using this CAM. You can tell your patients, well, it's not only about symptom control, it's basically about increasing self-efficacy or self-healing process. The other way of looking at CAM interventions is we try to install more resilience and more of cognitive reserve to the patient. I will give you a clinical example now. This is a 62-year-old patient with major recurrent depression, no psychotic symptoms, with prominent sweating, tremor, globus, and sleeping disorder associated with the chronic diffuse non-tumor pain syndrome of unknown cause. He was admitted for a relapse of his major depression. This is a standard patient in our setting, more or less. We continued cognitive therapy and recommended a follow-up on a personal diary where the patient had to develop insight on the positive aspects of biographic events of gratefulness. We switched to St. Johnsworth, 1800 milligrams a day, and the patient benefited from 2 series of full body hyperthermia. You increase the body temperature to 39 degrees, and you basically reset the immune system. This is nothing special about it. It's nothing dramatic about it, and there's no real side effects to it. Everybody who has children knows that a fever is good for the body, and this is what they're doing here. The patient got consecutive exercise programs, including yoga and a treadmill 3 to 4 times a week, 30 minutes daily. And we put him on high-dose vitamin D, 10,000 units over 10 days each, omega-3, Q10, and folic acid. We make good experiences with this vitamin. There's a long discussion in Europe and also in the US whether vitamin D is affecting the mood disorders, whether it's causal or only correlative. For me as a practitioner, when I read all these studies, they have one big bias in there. It's in almost all studies published, the doses is much too low. You're operating on 1,000 units, and with 1,000 units, international units, you are not getting very far. You need 10 times more to see a clinical impact. We changed the diet, including intermittent fasting, which means the patient is on a low-calorie diet, up to 300 calories a day, 1 to 2 times a week. When patients are non-psychotic and in a depressive state, they definitely benefit from it. And if you don't believe it, just do it yourself. I can recommend. This patient in particular was able to continue this lifestyle modification in a follow-up for at least 6 to 8 months of 1 day a week. And we recommended daily episodes of silence, including no exposure to internet. This is a typical case how it works in a rural, academic, ordinary teaching hospital, 724 with 2,500 patients throughout the year, doing CAM within standard care. Second example. This is a 42-year-old female chronic schizophrenic patient with predominant negative symptoms, a BMI of over 30, and a history of recurrent inpatient treatments for non-compliance due to ineffective medication regime and social withdrawal, presents to our hospital for exactly these same reasons. She's being treated with a 3rd-generation depot neuroleptica, risperidone, 37.5 milligram twice a month. And she's been attending a metacognitive training program with clinically, I would say, unsatisfactory results. We put her on exercise, including weightlifting 2 times a week. I don't know why weightlifting is good for these kind of clinical samples, but it is good. With a BMI of 30, she benefits from a specific mind-body eating program where the patients have to learn to eat slower, in silence, to chew up to 10-15 times, and to eat less. This also includes a selection of the diet where the patient refuses to eat fast food and drinks with the high sugar content. At our hospital, we are able to change the diet towards Mediterranean organic food, which is part of our standard procedure, and we supplement it with N-acetylcysteine 500 milligram a day. There is some improvement and some studies showing that this works, especially with regard to akathisia and lack of drive. This is not changing, this approach is not changing schizophrenic disorders, but it changes life satisfaction. It changes the clinical course, and it changes adherence and compliance in the patient. It's not healing schizophrenia, of course. A third example. This is a 28-year-old female patient with a 5-year history of anxiety disorder which had been treated as outpatient with a dual reuptake and with EMDR. She had an anxiety disorder which was associated with traumatic experiences, and she developed a low-dose benzodiazepine dependency. She's hospitalized for flashbacks and sleeping disorders, anxiety attacks, and an explicit wish to be treated with CAM. So also within our samples, within our cohorts, a relatively representative patient. During her stay, the therapy with the dual reuptake was discontinued. We continued EMDR in the stabilizing phase, and we supplemented with passion fruit, which has an anxiolytic property. The patient got ear acupuncture according to the NADA schema. Our nurses can do that. I trained over 80 nurses to apply NADA schema at ear acupuncture. It has very good effects on withdrawal syndromes and anxiety. I do not see any side effects. We do that several thousand times every year to our patients. The advantage of ear acupuncture, especially within the psychiatric setting, is simply that the patient doesn't have to get naked. So the ear is always feasible, and you can just put the stuff in the ears. So it's easy to administer. The patient got lavender aromatherapy at night and warm foot baths for better sleep. Nothing dramatic, okay? But foot bath increases the peripheral blood flow by vasodilatation. My grandmother knew already. And this increases the sleeping pattern. Has no side effects. Very cheap, effective, and no interactions with any other psychotropic drug. We could actually decrease the Z substances, zolpidem and zopiclone, by almost 50–80% on our wards by simply applying these basic measures. This patient attended a mantra meditation group. You know, there is preliminary evidence, and we see it also in the clinical setting, that the therapeutic property of a mantra is not only the tone and not only the content, but the repetition of the repetition of the repetition of the repetition. Okay, this has a healing property in its own. You don't have to go into the biography of the patient and work yourself through the biography from like a psychoanalyst. You can simply add a mantra to it. The patient can detach from flashbacks. And the patient got 90 minutes of walk in the park. Well, you say, what is walk in the park? Walk in the park is nothing special again. But if you offer this on a regular basis, you can measure heart rate variability, stress, cortisol level, mood, anxiety scores, vigilance. They get better after 90 minutes by simple exposure to nature. They definitely get better. So these are three representative clinical cases I wanted to further discuss with you. So when it comes to the question of applicability and future outlook, implementing CAM in mental health care, we have to consider the specific healthcare system first. Okay? It's not a fee-for-service, it's full coverage, and we have a lot of time for our patients. We have 24 days. I heard that your patients stay here much less than 24 days on average. So this gives us a lot of experiences in seeing clinical courses over 2-3 weeks, how they improve, how they get better, how they get worse, etc. Most CAM, not only European CAM, most CAM, including acupuncture and Ayurveda medicine, is unspecific. It's not specific for a disease within DSM-5 or ICD-10. It's unspecific. But the compilation of the different CAM tools provided by a hospital setting, tailored to the specific needs of the patient, can make such a treatment tailored to the individual patient. It's not a cookie cutter. It's a very tailored approach using the availabilities, patients' preferences, and what you have available on the wards. So it's not about every CAM, every time to every patient. Third, implementing CAM in a clinical setting means that we can increase adherence and compliance. I see dozens and hundreds of patients who do not come for their depot neuroleptica. They come because they want the ear acupuncture. I don't know what the molecular mechanism of ear acupuncture is on the brain, but I see the patient being more compliant and I see them improving. CAM has an impact on hospital management, staff recruitment, and costs. Since the last 6 years we've been doing that stuff, we were able to cut down the costs in drugs and medication by 5% each year. I mean, frankly, if you have more than 3 drugs, psychotropic drugs, any psychopharmacological regime gets complicated because you really don't know what's going on. It's 4 or 5 drugs. And finally, it's a stepwise approach. The standard guidelines and the conventional standard Western guidelines treating mental disorders is at its best if it comes to lab findings, imaging, and drugs. But from my clinical perspective, they lose part of their impact as soon as the mental condition becomes more chronic, more stress associated, more complex with regard to comorbidities, and more functional. I think, we just don't know enough in psychiatry that we can afford not to look what other medical systems been doing in order to treat patients. It's first time in medical history for us, really. It's first time in psychiatric history that we are able to witness all different systems on the planet throughout history trying to get the best out of it for our patients. I think that nobody is 100% wrong. Even we sometimes do not have the exact scientific evidence for the mechanism or the outcome in order not to consider it. What we're trying to do is an integral approach. Integral means the best of what we have in guideline and the best of what we have in CAM available to treat our patients. Thank you very much.
So, we have plenty of time for questions. Dr. Spa.
Yeah, very interesting, thanks. So besides patient preference and availability, how do you decide which of all these things to give to which patients in which doses?
Yeah, well, with regards to the big five, as I mentioned, changes in exercise, changes in diet, aspects of hydrotherapy, phytotherapy, and mind-body medicine, we try to apply at least 4 or 5 out of the 5 to each patient. Now the question of doses. With regard to exercise, I don't have a problem with the doses. I just see what the condition of the patient is, and then we see whether he needs a treadmill, or he needs yoga, or he needs jogging, or weightlifting. Okay? If it comes to supplements, okay, we got to go into literature and see, and also have to make personal experiences. If it comes to fasting or diet changes, from what I know, the last 6 years and the thousands of patients I saw, intermittent fasting is of good for the patient. Changes in diet is good for the patients. So I'm fine by looking at each patient, finding out together with my multidisciplinary team what's the best out of these 5, for example, the big 5 for each patient on top of it. Yeah.
Dr. Mahler?
Yes. I have to respond to the argument that you started out with. What you said, and you may be correct if I heard it wrong, you took the evidence supporting medical treatments that you demeaned it by saying that it mostly comes from industry, and it's weak evidence anyway, so maybe we should abandon empirical evidence and go and listen to vignettes. I mean, that's what it sounded like to me. And, you know, it's wrong on a number of accounts. One, the medical evidence comes from, it's rich, it comes from government-supported research, comes from, you know, a number of sources. I had to oppose that argument, which I think you were making, which I think is sort of not the way we argue within a university.
Yeah, very good. Well, I would not, let me clarify the argument. I'm not abandoning RCTs and research, but are we aware when we treat patients on a daily basis that at the most 25% is evidence-based, which doesn't mean that we should abandon that track, but the other 75% is anyway something which comes out of our clinical experiences and out of our training. This is the argument. I'm not arguing against RCTs. It's still important. It's going to be important for the future, and we need further drugs and further interventions. But I was not aware when I started training that the evidence is so low.
So, why don't we move this way across the audience and have a broader discussion?
You mentioned the treatment of your patient number 1, a number of treatments that were largely beneficial to the general population. And my question for you, I'm not so familiar with the German public health system. Here they are related but different, public health and medicine. Is there an effort to encourage these behaviors, exercise, relaxation therapy and so forth, in the general public apart from the clinical setting
Yes.
in Germany?
Yes. It's even reimbursed by our collective insurance. If you attend a yoga class, it's even paid.
Oh, even if
If you're not sick.
you need a diagnosis?
No.
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 Ah, wonderful. Wonderful.
No. You can attend a Reiki class and yoga class as a preventive measure being paid by the insurance.
This very interesting presentation puts me in mind of the impressions I've developed from can you hear me?
I can hear you, but I'm not sure about the audience.
Is the microphone working?
I don't think so, but if you speak up. Hello. Your voice.
Maybe it's possible to compensate by raising the pitch and the volume. What I was going to ask you is that if you have the impression, as I do, from looking at the descriptions of many different societal groups in the anthropological literature, that what various people have figured out to do for mental illness is to provide multiple varieties of nurturance. And I have the impression from looking at this literature that the number of modalities that are offered and given to the patient, many of which are described in your presentation, or at least similarities exist, is related to the efficacy of their efforts to help those patients. And this seems to be a situation that applies to hundreds of years of anthropological observations and reports. Now, I ask myself, what experience in life is in any way reminiscent of this phenomenon? And it seems to me that the answer comes across very eloquently, that it is the relationship between a mother and a baby. The mother does multiple things with and for that child. And it seems to me that that's got a lot to do with the efficacy of what you are doing with adults. It provides a belated repetition, maybe through regression, of many of the experiences of growing up and developing from a baby into an adult with the devotion of one or maybe several parents and others in that community. And the way in which those patients are able then to integrate themselves into the society in which they live seems related to the number of modalities that they have been treated with. I wonder how you feel about that.
Yeah, I haven't actually thought about it from that anthropological perspective of looking at the mother-child relationship. When I go through the wards and try to see what kind of intervention are done on a daily basis, I just often have the feeling when I speak with patients is that we are missing out very basic fundamental things. this example with that foot bath, for example. I mean, of course, don't go home and say in Germany mental disorders are treated with foot baths or something. Okay, this is not the message. This is not the message. But these additional interventions make the clinical course more sound. They make it different. Okay, and as the more acute a mental disorder is, of course, we use psychotropic drugs. And we lose psychotherapeutic interventions. There's no doubt about it. But the more chronic and complex disorders become, especially when we have 3, 4, 5 weeks paid by the insurance, we can see the course, what's happening, if I don't need Z substances anymore, or I don't need benzodiazepines anymore throughout the course. But the patient starts, for example, learning this mantra intervention, or she or he is learning exercise in silence, or attending a mind-body eating program where she intentionally refuses to eat processed food, you know.
So, if I may, I'm an advocate of foot baths. When I was a medical student working in the emergency room in London at University College, we had the head nurse of the ER was insistent that when persons came in who were in troubled circumstance, and sometimes they had medical diagnosis, sometimes they didn't, that they each received a foot bath. And it was quite miraculous, actually, what happened, because this was the first time that somebody had actually, it was almost biblical, you know, that they sat and they had somebody attend to them and bathe their feet, which they'd been using excessively, probably on the London streets. And it had a very genuine, I think, sense of engagement for the individual in that context of coming for some sort of solace and help. So if you extrapolate from that into a story about what human beings really do on a day-to-day basis, you know, I could make a hypothesis accepting that you are trying to integrate allopathic medicine with a cultural base that engenders a sense of community and attachment, which is what our friend here was talking about. If you think about that, then there's absolutely no reason why the bundling of these things that you're talking about shouldn't enhance the treatments that we provide in medicine. The problem here in the US is that we divide the things up. And we don't have 24 days in which to treat people in hospitals. So we have about, even in this hospital, which is considered one of the best around, we only have about 12 at most, probably average is somewhere around 7 or 8 days. So it's very difficult to implement and to induce new habits in a health system, because that's what you're talking about. I mean, unless all these people come in from the outside already having foot baths, already having exercise, already... They don't.
They don't.
So what you're doing is you're trying to shift the paradigm into a self-actualizing, self-beneficial
lifestyle modifications.
So if you think about like that, then that's a very humanitarian approach to a healthcare system. But it's also fairly expensive. Everybody of course, we know it isn't as expensive as it is in the US. We spend 15% of our GNP on healthcare. You in Germany spend around 12, as I remember, or maybe a little bit less. In Britain, they spend even less. So it becomes really, what you're describing, I think, is not so much a medical approach to returning to health, but a cultural approach to returning to health, because you've embedded the system of medicine within a cultural context, which enables us then to generate a different way of approaching the patient.
I agree.
And so immediately then the question becomes, because America, you know, is driven in its pseudoscience about what makes a difference, yes? So the first question I would ask you would be, given that you've been at your hospital for 6 years, what is the readmission rate of these patients? What is have you got any indices as to how they manage when they get out? Does the insurance company keep track of whether or not they come in less frequently after your intervention than before it, etc.? I mean, you get so it would reassure a medical audience in America if you were able to produce some statistics about it. And so I'm curious as to whether you or your colleagues have done any of that, because I'm a firm believer in the fact that a kindness and a culture which is sensible in regards to how the human machinery works will be beneficial. But unfortunately here we have a bunch of skeptics who won't pay us to do that. So could you help convince the Republicans in Congress that they shouldn't get rid of healthcare entirely and put it in the private sector? That would be very helpful.
Okay, I'm not sure whether I can offer that advice, but I looked at the data with regard to readmission rate in our addictive ward, because we have a lot of, we call it frequent flyers. They come in and out because of high alcohol intoxication and drug abuse, and we could cut it down by 80–90% in that, for that samples of patients who are frequent flyers, who were 8 to 10 times higher 6, 8, 10 years ago than now, who are now basically embedded into the social structure or into the societal structure without being readmitted.
So
I do not have,
you must have some sort of tail then after they leave the hospital. These habits, these new habits that you've taught them over a period of 3 or 4 weeks are reinforced by some system. Could you tell us something?
Well, the system is our outpatients department and our day clinics. You know, most patients who are attending the inpatients then are able to attend a day clinic and or an outpatients department, and we can decide within our system how long and how often we can see them in this setting. And in a rural setting like this, where we are responsible for 250,000 inhabitants, I'm responsible for the mental health care provision. And I'm responsible the way I'm doing it. I can shut down outpatients department and only have day clinics, or I can have less day clinics and more outpatients department. I can do it and organize it the way I think it's the best for these 250,000 inhabitants. Okay, and we can decide whether we discharge someone after 3 weeks already, or after 5 weeks, or after 1 week, and put him on outpatients or put him on day clinic. I have a lot of leverage to do it the way I think as a clinician is the best. I don't have to follow a 3 weeks guideline to treat a moderate depression over 12 days and then send them out.
You're going to have everybody moving to Germany soon. Any more questions? You had one here, I think, or maybe a...
Yes, I just wanted to comment on what the strengths of this approach are, and it's the emphasis of the strengths of the patient rather than weaknesses, identifying them as being responsible for their own health, empowering them to take this responsibility. And believe it or not, it works in most cases than not. People are like being empowered and feeling in control, and that's one of the approaches that gives this empowerment to the patients.
Yes. Question. Wait for the microphone, and we can all hear you.
Okay, so from your second study,
Second case study, yes?
you commented you're not really trying to, you don't believe that it's changing the schizophrenic symptoms, it's addressing a different issue. So I was just wondering if there are certain symptoms or even disorders that you think are better targeted with CAM as opposed to the conjunction scans.
Yeah.
Did you all hear the question? So the question is, are there certain syndromes which are better treated with CAM than others, such as schizophrenia, which was the point of this being?
Or symptoms.
No. Well, the clinical thumb rule is the more acute Western medicine is best. There's no doubt. I've been studying and working and living in these countries in other systems, and I know a lot of whole medical systems myself, clinically and practically. But the more complex a mental disorder becomes, especially with regard to comorbidities and with regard to chronicity, with regard to stress-associated variables. In the population, the clinical populations I'm seeing, I see that lifestyle modifications and CAM interventions are in part superior than just offering a drug and a psychotherapy. Okay, if you want to change on the long run the course of a disorder. Intermittent fasting is one of those. If the patient is open, have the preference to do it once or twice a week, it works. Yeah, for example.
So Dr. Bilder has the last question. Here you go.
Maybe I can holler into the microphone.
Yeah.
There's been some talk about what are the critical active ingredients. A number of ideas have been proposed. I'm just wondering, what do you think would be the most critical of these active ingredients of treatment that causes change, and what can we do to study it?
So the one with the highest impact?
Yeah, of these different approaches, it's obviously a very complex.
It's definitely.
Never study it all.
If I have one single thing to do, it's fasting. Yeah, fasting. Yeah.
We don't know about that in America.
I'm going to skip lunch.
Skip lunch. Okay.
So thank you very much. I think it's